introduce each of you. He'll run through the bios and then we'll start the conversation.
All right. Hello, everybody. Thank you so much for joining us on our monthly webinar for the Sam Alamayo. I'm a 2004 Rambra scholar and a board of trustee. I'm here with fellow board of trustee and partner on this webinar, Meredith Eggers. Meredith.
Hi, everybody. As always, thanks for joining us. And I just like to remind everybody, this is a place where we really want to be able to have really open conversations and be very frank. So don't hesitate to ask tough questions. And we'll start the conversation after Sam does the introductions.
Perfect. Thanks, Meredith. Today, we have a fantastic panelist of our fellow Rambra alumni to talk to us about COVID, shutdown, and the post-COVID world. And for us to have a frank, we welcome everybody to please raise your hand halfway through if you want to ask questions and join us with your video on as well. And the questions will be down there, and Meredith will be going through them and making sure that we all get to engage. Thank you for joining us. For those of you that are not familiar with the Rambra Scholar Program, the Rambra Scholarship honors the legacy of the late Secretary Ronald H. Brown, who tragically died in a plane crash that almost 25 years ago, exactly to the day. And the scholarship is a selective program that advances higher education for community-minded and intellectually gifted African Americans. The program supports students before entering college through the Guided Pathway Support Program, or GPS, during the college years through the scholarship and mentoring, and after graduation through mentoring and networking. Today, I am going to jump straight to our panelists. Without further ado, we have Dr. Travis Gales, a Rambra Scholars class of 1997. He is Health Officer and Chief of Public Health Services at Montgomery County, Maryland, my own county and public health star. He's been keeping us safe. Dr. Sando Bayash Ojukwu. She is a Rambra Scholar class of 2005. She's a pediatric endocrinologist at the Children's Hospitals of Philadelphia. And we have Dr. Tomeka Suber. She's a Rambra Scholar, class of 1998. She's Assistant Professor of Medicine and Preliminary and Critical Care at the University of Pittsburgh. So we have a fantastic panelist. And I want you to start, Dr. Suber, I'll start with you, just to give us just a quick background of what you're up to, what you've been doing, and a quick summary of what your career has taken you right now in the COVID world.
Yeah, how much time do you have? So as you mentioned, assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine, Pulmonary Allergy and Critical Care Medicine at the University of Pittsburgh. So I did my fellowship training here after completing internal medicine residency at Johns Hopkins, and essentially, stayed in Pittsburgh. And my husband and I have two children, ages 2 and almost 7. Which plays into our experience in the COVID world as well. I know that many people can relate to that. But for me, I'm a physician scientist, so about 75% of my time is research, primarily basic science research, and then 20 to 25% of my time in the clinical realm, which rapidly increased, particularly in the fall of last year. So every city around the country got their surges at different times. I would say Pittsburgh got the worst of it between frankly, Election Day up through the middle of January. And so for me, that's been a pretty defining period for me clinically. It's just living in the ICU and seeing the worst of our local pandemic, essentially, as far as the number of cases that we've seen, and feeling pretty tugged between my research obligations, for which I really can't do them right now when I'm spending a lot of time in the ICU, and then intermittent childcare issues. I think that's really what's defined my COVID experience. Not knowing if my kids were home for 6 months, and my son just went back to school in January. My daughter went back to daycare in September. So between March and September, it was both of them home like full time, with my husband also trying to work full time. So that's sort of been what's defined the past year for me.
I mean, it's just, I could just only imagine what you're.
You don't want to.
Yep. Dr. go ahead and can you give us a quick background on what you've been up to and your career?
Sure, I can definitely relate to that as well. Childcare, I think for many in the group, has definitely figured prominently in the past year struggles to magnify that. So I am currently a pediatric endocrinologist at the Children's Hospital of Philadelphia. That's also where I trained for my pediatric residency. Similar, but without the PhD, I'm also an academic researcher, but I delve more in clinical research sphere. And so our hospital, as well as a lot of other hospitals, shifted, and we had a priority towards patient care. And so all our research studies were essentially shut down from March. And then we started kind of a gradual phase return in July, August overall. And we're still not at 100% capacity for our studies. So definitely, in terms of the research sphere was impacted. And then most especially, I would say my time is split 80-20, 80% in research, 20% in the clinical realm. And so even just the way my clinics changed in terms of before we didn't do any telemedicine to at one point, we were almost 100% telemedicine, which worked great for things like my diabetes care and not so great for some of the kids who were concerned they were having early puberty. You can't really do genital exams online. And so happy to delve into that as well. But from a research perspective, from kind of a family perspective, living in Philadelphia with my son's about to be 2 years old. And when the pandemic happened, he was like 6 months. And so we had a nanny initially, and kind of with the restrictions at a point, working from home full time, both my husband and I, and trying to juggle childcare before we eventually put him back into daycare in September as well. And then, of course, with kind of all the racial reckoning that was happening in the United States as well, I would say that prominently figured into this year as well, and kind of the impact that had personally in our community, and then even in an institutional level, and trying to make change at work. I'm happy to talk on those things.
Thank you so much. Dr. Gales, kind of from your end, I've been very familiar with your work and its impact on my own community as well. And of course, kind of the very public presence of your work, and congratulations on the recent coverage. I guess I should say congratulations to 60 Minutes for the recent coverage. For those of you that haven't seen it, please tell us a quick background on kind of your work, and you come at it from kind of a unique background of kind of public health.
Sure. Good afternoon, everybody. Always fun to be back with familiar folks and faces. I hope everybody's continuing to stay safe. And my trade line is stay safe, stay sane, and stay stress-free. So hopefully all of that is covered across the board. My role has been, I'm not a practicing physician anymore, at least in this capacity. I'm a clinically trained pediatrics guy and adolescent medicine focus, but I'm an administrator now on the public health side, coordinating and leading our COVID response that spans public health services, as well as emergency management and homeland security and emergency preparedness division. So I've had a front row seat to, on the other side of things, helping shape and craft policies that ultimately, hopefully, will keep people from seeing Dr. Super and Dr. Ojukwu, from having to go in, and whether that's from testing, implementing requirements around face coverings, all that stuff, to business restrictions, school restrictions, to now overseeing our rollout of our vaccine program to hopefully get more people covered. I do not have any children of my own, so I cannot speak to the child care actually in person, but in terms of what went into developing those policies related to those particular areas, from the government side of things. I went into medicine not as an elected official or as a politician, and have unfortunately been in the mix of quite a bit of politics, as the public health response has been complicated and politicized highly. And if you've got any questions related to that, we'll be happy to share some war stories. It's a safe space, so I will be as candid as possible, and happy to be on the record if anybody leaks it to the press.
Yep, go ahead, Meredith.
No, I just thank you for that, and thank you for your backgrounds, and thank you for what you all have been doing for the last year, because it's been a hard year for almost everybody, but I think for healthcare providers and folks dealing with public health, it's been brutal. And I'd like to hope that the sea change of politics has maybe improved things. So the last time we talked about COVID was midsummer, I think, and we were in a different administration, but maybe just quick response, and Travis, maybe you start on how the political climate is it improving? Does it feel like we've got a better shot at moving forward, or are we still, has the administration change helped?
Well, the short answer is yes, it has. If for no other reason that there are actual plans in place now around, testing and vaccination distribution, as well as, thinking through lenses of health insurance access and how all those things factor in and influence COVID response. When, for the folks at home following, when they were saying that there were no plans in place, there literally were no plans in place. Like none. So there was no vaccine, but there was nothing. And we were going off of just trying to guess and put in stuff as we were finding out information. So it has improved from that perspective. The challenge is that the new administration is having to fight off a lot of that lack of planning that was done before. And they have ramped up, particularly in the vaccine space. We've seen a significant increase in the capacity already supplied, as well as what will hopefully be delivered. And our timeline has shifted from potentially looking at early fall, when we would be able to have adequate supply, to, sometime hopefully within the next 6 to 8 weeks, where we would have enough vaccine available to get people vaccines who want it. Now, the longer term perspective is that I think, unfortunately, the new administration doesn't have the time and energy to fight all of the different things that have hampered the COVID response, including longstanding health disparities, longstanding issues with meaningful access to health insurance. And, COVID has highlighted some other things that, particularly in the area of housing security, which has influenced how easily things have spread. Affordability in housing influences how many folks you've got living in your space. And we found here that families were transmitting into others, where they've got 3 families living in one house because nobody can afford it. And one other thing I threw out is, when we look at the economic divide and impact of this public health experience, it should not surprise anybody when you look at types of employment that have been hit hardest by COVID cases, because the same folks who we've asked to go as essential employees, we've asked to work to keep the economy moving and resources open for all of us, are not afforded the opportunity to telework or have access to paid family leave or paid sick leave. And so those types of non-medical and non-public health things have influenced, public health response. So I'm hopeful that with the new administration looking at all those different things, that will help move us through this and hopefully offset some of those precipitating factors that have caused the huge disparities in COVID outcomes.
I commend Travis on everything that he's doing, and everything he said was on point. For me, I'm in a different location than Maryland. So I'm in Western Pennsylvania. So it's a little different demographically. So I'm in the city of Pittsburgh, which is fairly diverse, but it's pretty segregated. But I'm in like deep red territory if you look at the political climate. And I'm pretty convinced that there was this huge Trump rally that had 50,000 people the week before we started seeing a crazy surge. And I really feel strongly that it was tied to that rally, but no one said that explicitly. So my experience on the clinical side has been interesting in that we got a lot of patients particularly before Biden's inauguration, just saying like, there's no way I have COVID. These are mainly white working class patients who were in complete denial of their diagnosis all the way up to the very end. I had patients who had Trump manicures who were dying in the ICU. So I think just like for me, as far as what I've seen, there's a huge disconnect, and I think that's going to take a lot of time to resolve. And I'm not sure there really is a resolution for it because people's belief systems are heavily entrenched. And I think it's been helpful for me to at least see that perspective and to not think that everyone thinks like me because of where I am. I grew up in a fairly integrated area in North Carolina. I did a lot of my medical training in Baltimore, and then coming here, it's been eye-opening in a lot of ways. But I think that contrast between seeing people who just don't want to get it versus running out of body bags at one point, running through the list of ventilators that we had. Did we need to pull ventilators from other hospitals to accommodate just the number of intubations I was doing on a daily basis and paralyzing and proning half the ICU? I think for me, that's what I've really struggled with, especially in the depths of the surge, is just trying to navigate the disconnect, and that, you really can't focus on it. You just have to do your job. So the political climate was certainly the backdrop to a lot of my experiences, particularly in the, from November to, the insurrection to, inauguration. And then we finally started to see numbers come down. But I think it's going to be a long road, and there's still a lot of vaccine hesitancy. There's still a lot of denial of the severity of COVID. And I think as we see spring breakers doing their thing right now, we're expecting another surge in the next month or so. So we have to sort of see how things pan out. But I think the political climate at least allows us to have more of these conversations openly and have more data out there to back it up. And I'd certainly echo what Travis said as far as having actual plans. Can't stress enough what a disaster the vaccine rollout was. And in some areas continues to be, but I think it's improving. But I think that's where we really need to focus our efforts, educating the public, vaccinating as many people as possible, and keeping them out of the ICU.
I agree with everything that's been stated. So I'm part of the sister city, but in Philadelphia, definitely. So I'd say in terms of the political climate, I hadn't seen a significant shift since the election overall. What I did see during the election period was the hospital made a more concerted effort to kind of engage in politics for the first time, even though they tried to stay apolitical. We had a huge get out the vote campaign. I think it was recognized the importance of health and kind of policy and just overall asking people to get out the vote. So all physicians got signed up for name badges that had voting campaign stickers on it, just saying like, have you made a plan to vote? And was actively encouraged to just have people think about voting and registering, of course, not saying who to vote for or things like that. And then I would say, since with the new administration, because there are plans, I think they've done a better job of creating partnerships. So my hospital in particular, we have been the main site to vaccinate teachers within Pennsylvania, within Philadelphia anyways. And so we are currently getting all teachers vaccinated, and then Pfizer is the only vaccine for kids under the age of 18, so 16 and above. And so now we're also actively having all our high-risk children vaccinated. And just the fact that we have plans, we know how much supply, and we have personnel on staff, we've been able to help in those efforts. And I think those efforts have gone further because of those partnerships with the plans laid out by the new administration.
Dr. Ojukwe, I think we have a question for you from Terry Dean, a board trustee emeritus, saying, of course, you're in Philadelphia right now. If so, are you engaged with the Black Doctors COVID Consortium?
Yes, so I am in Philadelphia, and the Black Doctors Consortium is a phenomenal group. I've sent in my volunteer paperwork, but I have not gotten my first shift yet. For anyone who's unaware, The Black Doctors Consortium is a phenomenal organization. It's a nonprofit that started probably in March or April, sort of at the start of the pandemic, where, I'm blanking on the main physician, Dr. Ava, I'll look it up. But she was kind of hearing from her neighbors who were some Black physicians like herself, and also just church members and others, that they couldn't get vaccinated, or they couldn't get tested. They were having, and so she was able to gather supplies and initially just started from the back of her van, going out and testing individuals. And since then, her organization has grown. In fact, last month, they had a 24-hour drive where they vaccinated over 3,000 people in one day as well. And so now they're not only testing, but they're vaccinating, and they're also applying an equity lens. And so they're looking at the hardest hit zip codes within Philadelphia, and those are the people they are prioritizing as well. So I have not had my first shift with them. I am volunteered with them. Thank you, Dr. Ayla Stanford is her name. Thank you, Terry Dean. So I'm registered, but I have not had my first shift yet.
And thank you so much for telling us about kind of the organization. That sounds fantastic. I want to piggyback to that to ask the question. We were discussing it earlier. COVID has exposed the healthcare disparities, as you were saying before we got on, Travis. These are problems that have always been there. They just got exposed. Are you seeing, are they being solved with a permanent solution, or are we just seeing bandage on them? And what are some of the things that you hope and you wish to see kind of going forward, so that we don't see the repeat of the same things because the underlying problems are not being fixed?
That's a great question that we grapple with, whether we're on the admin side, the public health side, or the clinical practice in terms of interfacing in the hospital and the clinic with patients. So the short answer is no, we haven't fixed those. And quite frankly, we've continued to struggle with it because part of the challenge is we have to acknowledge that they're still here. We've become very good at renaming it. I remember when I was in college, that was when health disparities was really getting a lot of attention. The IOM report in 2001 talked about unequal treatment. And it's gone from naming health disparities to health inequities, to health inequalities, to health inefficiencies, to the social determinants of health. And so we keep renaming it, but we're not actually solving it. And I think part of the challenge is that I think there's been an acknowledgement that clinical medical issues can't solve it. And there has to be a full review of how systemic factors that are non-clinical, housing security, food insecurity, education access, employment access, transportation access, safe neighborhoods, zoning laws where you determine where stores go to, for grocery stores or other retail opportunities. We have to really sit down and have a full conversation about how all of those factors play a role in health outcomes. And then when we have those conversations, I think we have to have a more candid conversations about the influence of racism, bias, whether you're talking about it from race and ethnicity, gender, sexual identity, gender identity, geography, immigration status, how all of those things influence those policies, which then translate into impacting health outcomes. So I'm hopeful that, unfortunately, COVID has reminded us of that, and I hope we don't have amnesia when everybody's vaccinated and we go back to normal life, because I think this is the opportunity to have that type of substantial discourse to come up with these solutions to fix things. And so the example that I would throw out there is it's non-COVID related per se, but it is factoring in COVID. It's the housing issue. And we've been talking a lot about this in terms of housing stability for diabetes management, as well as housing stability for HIV management, for prevention, as well as treatment. And we know that when folks are stably housed, they're more likely to be adherent to their medication regimen. They're more likely to be adherent to their appointment schedule. They're more likely to have access to educational and economic opportunities, which would support them and have the social support in place for them to be able to focus on their medical issues so that ultimately they can improve their health outcomes.
Yes, and certainly, like, from the perspective of the academic space, I feel like we have done many research studies that confirm health disparities and health inequities. We can predict the outcome of many of these studies just on the basic premise of the question, right? We sort of know that there are hundreds of years of disparities that have built upon each other up to present day. And so what I would like to see more is what Travis is doing as far as trying to impact policy. Policy is where we have the deficit, right? We know what the issues are. I think we've identified them. They've been well studied. They've been well documented in the medical literature, but we really need more policy to be crafted in accordance to with those deficits and to address them. And I think the second comment I wanted to make is within medicine itself, I can use the example of calculating renal function, kidney function, and how just the algorithms that we use enhance disparities for renal transplant for Black patients, right? These are things that within medicine we can change, and there has to be a will to change it. There's a lot more discussion about it, but I don't see actual changes happening. So even within medicine and some of the algorithms that we use, that can also worsen disparities. And I think that we also, on the academic end, we can maybe address that within our own profession, but to actually impact the social determinants of health, we need more policy, and we need more people working in the public policy and public health space to help craft that.
And certainly COVID is only, I think, increasing those disparities, if anything, instead of creating permanent solutions to those. I think, especially people in the medical world have known about these disparities. Maybe it's becoming more known to others. I would say, I think a study I read recently said that maybe 20% of the care that we give medically will actually impact long-term outcomes, and that 80% of the care or outcomes is due to social determinants of health. So that's things like your school system, your housing, all the things that Dr. Gales was mentioning. And just to shed light on that, a month ago, I had a patient who has type 1 diabetes. His grandmother is his primary caregiver, and she was scheduled to have a surgery. And because of that, she had to do COVID screening. And so she came in, she got her screening, found out she was actually positive for COVID. She was asymptomatic at the time. 2 days later, he became symptomatic, and they lived with her father, who was in his 80s battling cancer himself. And so we were able to get short-term housing for them through the city, but that doesn't solve kind of the long-term impact. Not only that, but she's not technology literate. And so he has missed a lot of school over the course of COVID, has not been registered as well. And they've also been moving between homes, not having adequate internet access. And so this year has been a wash for him academically. Because of COVID, we've been able to switch a lot of our visits to telemedicine. And I've been able to see patients kind of more frequently to check in, as long as they're able to download their devices. He's someone who right now does not have a device that can be downloaded, partly because grandma and him are unable to access internet and don't have a reliable computer. So he's someone who I've been trying to see in person, and transportation difficulties have made that more difficult as well. And so he's just one case study, but I would say in those who already we know are impacted the most, COVID has only increased those divides. And I think there's a lot of talk now on inequalities, but really the solutions are not the sexy solutions. It's not like the new drug that's going to fix anything. It's investment in things that we already know, like housing policy and safe schools. The school that he would be going to in Philadelphia, you're not required to have a nurse on site every single day. And so for some of my younger kids who are 4 or 5 that have diabetes, parents or teachers have to be the one to dose their insulin during the day. So it's very much kind of outside of the medical sphere and really engaging all aspects of care. And so it's harder to have those long-term solutions, but necessary.
Wow, I mean, that's, first of all, thank you so much for what you guys are doing. And, just listening from what you've said and what is happening, if a once in a century event is needed to, one, shade light, and then second, is not a catalyst to actually bring about change. It's terrifying of what could bring that. And so what are some of the things kind of from everybody that is on this chat, that recommendations that you could do? Of course, go out and vote and make sure that policies are done the right way. What are some of the solutions that you would recommend? Because it's like, it is very acute and it is very scary. If something as big as COVID, because everybody has been talking about COVID being this big reset. We've gone through such a horrible thing, but the glimmer of greatness was that, can this be a catalyst for change? How can we make sure that we don't lose that? And how can we still use this event that have woken up everybody to be able to see this underlying issues that touch not just the African-American community, but many communities based on socioeconomic status, but specifically communities of color that have been affected the most. Can you tell us kind of a bit of kind of specific recommendations of what we could all do and we could all rally around? Not to put the spotlight on you on solving it at all, but anything that you could recommend would be helpful.
I'm happy to take a first crack. I think there's two things. I think recognizing the diversity of the professional backgrounds and professional interest of everybody within the program, whether we're talking about scholars, alumni, or friends of the program, it is thinking through a lens of the name we have it in terms of the model we use is called health in all policies. So thinking through when you are crafting your particular plans, laws, rules, or whatever in your particular field, taking some time to think about the impact that will have on the health of the folks in the lived environment within which those policies are being enacted. And so, whether it's, making a decision about where a store goes, if, it's a food store, for example, that is off, has fresh produce and those kinds of things, thinking about the impact of locating that in an area that is medically underserved or does have a high prevalence of, type 2 diabetics or heart disease, and improving the proximity they have to those options to be healthier and more nutritious. Or when you're thinking about putting in sidewalks in a community, thinking about it from the perspective of pedestrian safety, but also the number of kids there. Is it safe for them to play in the neighborhood? And, when you're looking at obesity rates, we tell people eat healthier and exercise. Well, if I'm in a neighborhood that doesn't have access to a place with healthy options, that's going to be tough. And then if I don't have a lived environment that's safe and is accessible to be able to be outdoors, it's going to make it also challenging for me to do the exercise that you're asking me to do. And I think the other thing is, since we've got these two powerhouse academics on, and I would love to hear more about their work in the area, is we've got to ask research questions to get the data. So particularly as it relates to the health, the looking at systemic factors and systemic racism in health outcomes, one of the things that I've heard people say is, well, it's impossible to measure that, or there's no data on it, so we can't come up with policies. That's BS. And so I think as we continue to ask those questions, and representation matters when we have people who look like the communities that are being hit hardest in those spaces, those questions get asked and that data gets presented. And so it makes it a lot more difficult to dismiss it, but then it also can translate these ideas that are abstract into numbers. I think of maternal and infant health, for example, where in public health, we always control the way things and say, well, if you control for socioeconomic status and education, that solves it. No, it doesn't, actually. And when you do control for that, the disparities stay. And so there has to be something different. And so, asking those questions to talk about how you can start to quantify in a real sense of cases, economic impact of how, racism and oppression, those kind of things impact those health outcomes. So I think those are two probably the biggest things from my perspective.
You want to go ahead and say something?
Oh, I just wanted to piggyback on kind of your maternal, the infant mortality and low birth weight babies are a really interesting example, because I think a lot of times in research, like you said, we're like, unfortunately in the US, kind of socioeconomic status and race are very much intertwined. There's additive and multiplicative effects. But even if you look at something like low birth weight infants, for example, if you look at Black women, so Black women are more likely to have a low birth weight infant if they are college educated compared to a white woman who hasn't completed high school yet. And so we're talking about people who graduate, even if you look at people who have professional degrees as well. But if you look at a Black woman who is immigrated here, so was born in another country, let's say I'm originally from Liberia. So if my mom, for instance, so a African immigrant is actually more on par with a college educated white woman. But within one generation, so my mother's child, me, that child is more likely to have low birth weights compared to a Black person who's lived in the US. And so within one generation, that's not genetics. That's very much the environment that you lived in. And so there is more research that's showing kind of that growing up in the stress of the race, all the like microaggressions and racism that you experience is not protective against kind of if you're highly educated, if you have high social SES and things like that, that there's a lot of psychological stress, and the impact that that has on your body can also translate into things like birth weights. So that's just a great example, and ways to impact that. So one of the things that emerged out of kind of George Floyd and the Black Lives Matter protests was for the first time, my institution, as well as the adult institution Penn, required that all professors and clinicians had to do implicit bias training within the next 1 year. So that's one step, right? At least starting to think about your implicit biases, and we all have them, whether you recognize it or not, and how they're impacting the care that you're giving others. So I think there has to be kind of the national level changes kind of with our politicians, and that can be on a local level as well. And of course, there's the individual level changes. So that's like serving on our school boards and being a voice. I've started to do a lot more book clubs during this season, and also just trying to kind of support my local Black bookstores and things as simple as that. I think there's a lot of changes on different levels as well.
Yeah, I just want to make a comment more about holding healthcare systems accountable. And so one thing I've really been interested in, particularly because I'm in a very large integrated healthcare network, is sort of understanding how that can exacerbate disparities. So again, I'm a physician scientist, I do lab research. So I'm not a policy person, I don't do research in disparities, but I respect the space. But when you have these large healthcare systems, if you've noticed in the past several years, and not just in rural areas, but in urban areas as well, some of the hospitals that served the communities that need healthcare the most and need high quality care the most are closing. And so that actually has exacerbated many disparities in urban centers as well as rural areas, because there are just fewer hospitals for these populations that already have significant disparities. And it's from a profitability standpoint that these hospitals are closing, particularly when they get acquired by larger healthcare systems. And I think that unfortunately, many leaders of these healthcare systems are also politically tied, right? So they can donate money, they can sort of make sure policy is friendlier to them when it comes to these acquisitions and these hospital closures. And if I remember correctly, someone can correct me if I'm wrong, but I remember I think Hahnemann closed, or in Philadelphia as well. And I remember being like really upset about that. So I think, yes, public policy is very important, but I think we also need to hold leaders of our healthcare systems accountable, because these systems are becoming larger and more integrated, and these smaller hospitals that had a specific purpose in their own communities are closing as well. And that's really exacerbated disparities and limited options. You know, some patients cannot take 3 buses to get to the nearest specialist for their specific healthcare health condition. And I think that's something that's being ignored because these healthcare systems are very profitable. But I think people need to be clear that they're exacerbating the problem as well.
I think that makes a lot of sense. And this is, I know, a big question, but to follow on that, does nationalized healthcare, or a system of nationalized healthcare, does it help, or does it just complicate, or does it do both?
I think it in itself alone is not the solution. It's got to be all of these other things that go into play. So, to Dr. Stuber's point about you can say, hey, here's insurance over here, but if I've still got 20 obstacles in my way to get there, that in itself doesn't fix it. And so I think, again, that goes into kind of the planning. I think increased access to care is extremely important. Increased access to meaningful care, let me rephrase that, is important in terms of what you do have access to and subspecialists and those types of benefits. And so I think I see a question from Terry in the chat related to, is policy setting more critical at the state, federal, or federal level? All of the above. And I think it's working hand in hand. Federal policy that can help influence state policy that can work with local and regional approaches, I think is necessary for all of this to be successful, because in many ways, the federal and state levels determine the funding and the restraints within which we can do at the local level, which is actually, on the ground, making the decisions about education access with, local school boards, making the determinations about where those bus routes go at the local level. And, those zoning decisions and, whether we're talking about store placement or housing opportunities and, helping to level set the market so that it's affordable.
I'm going to leave it to the now career politician, or I'll leave Dr. Gale to answer that one.
I'm not an elected official. I do not make political decisions. And Sam can tell you, I have said that on multiple briefings to remind people we make health-related decisions, not political choices.
Okay, so change gears a little bit here. I think one of the concerns that many people have voiced is the portion of the population that is going to or already has declined to be vaccinated. So talk a little bit about that. Talk about how you talk to your patients who decline, and give us some language that if we've got a relative or a neighbor or anybody that's saying, yeah, not me, no thanks, other than just saying science, how do we get everybody vaccinated when vaccines available?
So I'll jump in here because I do research in COVID, and we've been addressing this issue in Pittsburgh. So I guess the first thing is that you have to approach it from a position of trust. So the patient has to trust you, and they have to trust what you say. And I think a lot of the vaccine hesitancy is related to centuries of reasons why people don't trust why particularly Black people, Black and brown people don't trust the healthcare system. And so I think having that understanding in the background is very important when you approach a patient, particularly a patient of color who has vaccine hesitancy. And so I'm part of the Speakers Bureau group in Pittsburgh that basically is speaking to different community groups about the vaccine, sort of presenting the data and doing like Q&A sessions with these community members and leaders just to address some of these concerns that are reasonable. It's just that we want to make sure people have the evidence and break the evidence down in a way that's understandable so that they know what they would be getting if they got the vaccine, what are the side effects, what is the efficacy, and why, we recommend it. Certainly from a medical perspective, and given what I've seen in the ICU, I'm always going to recommend the vaccine, but want to make sure that patients understand that they have choices and that the goal is to give them information. But I think it, again, has to be from a position of trust with the patient and also non-judgmental. I think if you're like, well, the science is showing this, then people automatically have resistance and they're going to feel like, you're just trying to sell me something. I'm not trying to sell someone a vaccine. I'm just trying to basically give them the evidence to support why they should get it. And I also don't promise people that they're going to feel great after the vaccine. I happen to be one of the people that didn't have a lot of side effects. I have other friends, colleagues, et cetera, who were totally laid out for 1 to 2 days after getting the vaccine. And so I think being honest about the side effects, being honest about, especially if you had COVID before, a lot of people have more significant side effects with the vaccine. These are things that we can convey to people, but I think trust and being non-judgmental have been at least the key things that we've been, focused on when giving the community information and making sure that they have what they need to make an educated decision about the vaccine.
No, that's fantastic. I wanted to kind of tap into one of the questions that is asked on the chat, again from Terry Dean. Is policy setting more critical at the state or federal level to mitigate inequities, or both? Does one outweigh the other? Anybody wants to take that?
I think they all go together. I think, some of the feds can move more mountains from kind of a seismic level, but the benefit of the local and state level is that you can make those policies more personable and specific to your particular jurisdiction and location, so that it's translated in a meaningful way. And you take this big, huge policy and translate it into something that is respectful of the different dynamics and demographics of the respective communities, so that it actually isn't just this bulky law or bulky commitment of resources that goes unused or is used improperly, to minimize the potential effect of it. That's just my thought.
So the last time we got together and talked specifically about COVID from a medical standpoint was middle of last summer. It was sort of in the thick of it. And I think we all hope that we are approaching some at least start of a resolution, start of a movement forward. As clinicians and as research physicians, do you think that's realistic? I mean, I know, Dr. Suber, you talked about the fact that there's a very likely next surge. But what do you think the next 6 months look like? And we won't hold you to it.
Yeah, I mean, I'm probably, again, a little more pessimistic because what I've seen has been the extreme end, right? Like I see the worst cases and I've, been in a full ICU for months on end type of thing. I mean, I think we can expect to see a new baseline, meaning we're going to always see COVID. I think this idea that COVID is going to go away sounds absurd to me, just like flu never really went away, right? But I think we're going to have cycles of seasonal COVID, I think is what we're going to end up seeing, just based on some of the acquired mutations that we're seeing and the variants. And so I think we'll have a new baseline steady state where we're going to see consistent COVID cases come in, but hopefully won't be overwhelmed like we were in the fall or like New York was last spring. And I think every time there's an event, like meaning, holiday or, something like that, I think we're going to see a blip after those events. It's just hopefully we won't be overwhelmed again. And I'm hoping that overall severity of disease goes down as we vaccinate the public, right? So one thing I did want to point out, and again, this is probably why I'm a little bit pessimistic, is that in Brazil, for example, if you look at the fact that they essentially had unmitigated spread last summer of COVID, and then it was like maybe around May, extraordinary number of cases. And then you look 6 months later and they got another surge. And so there's this question of whether or not the immunity that you have after being infected with COVID, you're looking at about a 6-month period. Now, is that true for the vaccine? Can't really say because we're still getting that data. So I think we have to be realistic in expecting that we're going to continue to see COVID have peaks and waves in the future. What I'm hoping is that we at least have some baseline herd immunity, meaning a lot of people have been infected, a lot of people get the vaccine, the overall severity of disease as people get infected with additional variants later down the road, that their disease won't be as severe. And then, from my basic science background and my perspective and the areas of research that I'm involved in, I'm hopeful that we'll have more, have better treatments and targeted therapies for disease that comes into the ICU. What we have right now, the data is not really so great. We sort of do what we can. I think steroids are pretty much the most effective therapy that we have. And that's not a brand new novel therapy, but it seems to work for these patients, or at least a proportion of them. But I'm hopeful that as we, engineer antibodies that can target COVID or target SARS-CoV-2, and hopefully decrease the severity of infection when patients get hospitalized, I'm hopeful that those therapies will come through the pipeline in the next several months and we'll see some better outcomes.
So I will try to paint a more rosier picture. And Dr. Suber, you should correct me because you are more steeped in the COVID literature. But to my knowledge, anyone in the US who has gotten a vaccine has not died from COVID. So I would say overall, as we're looking, I think what has been especially brutal about COVID and the healthcare system is that basically we were running out of capacity. Both it was spreading, that those who had underlying conditions were getting especially sick, and overwhelming our healthcare system. Even when we look at vaccine efficacy rates that quote kind of 79% or 85%, when we look at the measures of who is having to get hospitalized, those numbers are like less than 1 or 2%. And we've had no deaths at all. So in that regard, I'd say for the population who has been vaccinated, and maybe to some extent those who have natural immunity from infection themselves, you can almost, I would say, through the summer, and especially as we're seeing with the new CDC guidelines, start to have a return to a new normal in a sense. At least for me, I'm more apt to kind of see my parents this summer after they've been vaccinated. We're obviously going to be outdoors, but even now, same household, being able to like eat together without masks, and even those little pleasures, even though it's not the normal that we know that that's something that can be done safely at this point. And so I'd say in the next 6 months, maybe not, definitely not a return to the normal that we knew, but at least with the things that we have now and the vaccines that we've seen, looking at rates such as hospitalization and certainly death, there's been substantial improvement. And even just the vaccines themselves, the fact that they were created in over a year is really a applause to modern science.
I guess I would be somewhere kind of in the middle. I won't say happy or sad, but maybe real from the other side. I think there is cause for optimism in terms of, again, getting access to the vaccine is important. And I saw a question in the chat room. I think the new normal will be getting, to Dr. Suber's point earlier, is getting a booster every year. I think it'll become a part of our routine vaccine, yearly vaccine process, as we do with the flu shot. I think all of the manufacturers are gearing up with that expectation. And so I think to offset potential waves in the future, we'll probably see a big push for vaccination later this year. But hopefully by then we will have the infrastructure in place so that it has become routinized, where you can go to your regular provider and we don't have to do mass vaccination sites like we're doing right now to get everybody across the first finish line. So I think that's the first thing that we will get back to a new normal, but that'll be a part of that new normal in terms of that expectation. I think the other thing that will influence this, well, two other things that will influence it, is the first one being how we look at public health issues from a political perspective, and how we weigh public health concerns versus economic and political perspectives and business interests. I think this is probably the first time in our lifetimes where we've had to have that discussion, because quite frankly, public health is usually an afterthought, and for the first time it's moved to the front of the table. But we've had these discussions where we're trying to do we reopen businesses even though we know there's a whole lot of variance out there and the numbers are going up, but I've got to protect this and I got to get kids back to school and all those other things. And so hopefully there will be meaningful, the next time around, if this happens or something else happens public health related, there will be more integration of those as opposed to putting public health on one side and economics and business on the other side. It's not a versus battle. I think we can do both in a meaningful way. And that gets me to my third piece as a public health official, is we cannot continue to underfund public health infrastructure, in terms of supporting, it's interesting, the thing I'll throw out is when people were talking about contact tracing. Now everybody wants to talk about contact tracing like they know what it is. Well, the reality is in the last 5 years, contact tracing budgets have been sliced majorly, significantly. So when the first idea came up to do contact tracing, everybody's like, well, where are all your contact tracers? Well, we had to let go 50% of them the year before because the budget got cut. And then the year before that, 25% cuts. So I think, moving forward, that we will continue to support and fund public health efforts in a meaningful way in terms of workforce, in terms of technology. You know, at the beginning of the pandemic, we were still relying on fax machines to get results. We're 2021, we shouldn't be in that situation. So it'll take an investment in the public health infrastructure, which I think will go along with the medical improvements of treatments, access to care, all those things that hopefully will not put us back to where we are today.
Yeah, I think that's what we all hope. And we appreciate the fact that you three and many, many, many others like you have been working so hard for the last year to try to just get us to something that looked like normal again. And the mental health costs that we haven't gotten to talk about today, and the One Health aspect of this is probably not the last zoonotic disease we'll see, maybe even in our lifetime. There's still a lot that we could talk about, but I want to say thank you for having this very candid conversation today. And I know Sam probably has maybe one more question, and then if there's anything else you guys want to close with, we're sort of getting close to 11 o'clock. Well, where I am, we're sort of getting close to 11 o'clock.
No, absolutely. No, thank you so much for your time. With the opening you've given me, Meredith, I'll just add one more question. You know, the one thing, especially talking with Silicon Valley, is this idea that technology will be the solution for a lot of stuff, and I think technology would definitely play a role. This idea, and the one thing that you've highlighted very well are there fundamental things from housing to learning loss and food deserts in a whole lot of different communities that somehow, you're starting to see a lot of telemedicine, healthcare kind of infrastructures being invested. Is there this thing that we somehow will leapfrog and people will just say, ooh, like a lot of this company will take care of it, this app will take care of it, and it may detract from actual core infrastructure and core investment coming in? Where are you when it comes to kind of the balancing act between private sector, technology-led private sector, solving a lot of this gap versus just traditional investments that just need to be put in?
So I guess this is where I'm a little bit less rosy. So maybe we'll be able to switch here. As someone who takes care of a lot of patients who have diabetes, technology has really been at the forefront for the past 15 years. We are at the point where we have insulin pumps that are automatic. You can read what your blood glucose is. It can try to auto adjust and we call it artificial pancreases, essentially. And what the studies show though, is that they've only widened disparities. So when you look at people who have access to these insulin pumps, it's unfortunately Medicaid, the insurances are not always covering it. When they are covered, families may not have the social support networks that they need, that if mom is working, that there's someone else available to help young kids utilize the technology correctly. So I feel like a lot of times, once again, that we try to do what's flashy and like a quick solution, when what we need is really an input into the things that we know are sustainable and will have that big impact. Those policy changes, that housing, investment in our schools, I think that is what's going to be the long-term solution. I think technology will certainly help, but personally, I've just seen it widen the divide when it comes to diabetes care.
I totally agree that telemed, I know that people are really excited about it, but I'm just seeing that it is exacerbating disparities in other ways, just because not everyone has access to a smartphone. My elderly relatives are not on a smartphone trying to register for a vaccine slot, for example, which is, these websites are being used to disseminate slots, but not everyone has access to that. I think technology, I'm again skeptical because I think technology has been used to spread so much disinformation that's actually made it so much harder for us to do our jobs as healthcare professionals in the middle of this pandemic. And, you know, I think that if it can be used to spread more information, then we'll hopefully see people respond to that and actually support improved policy changes. I still think the fundamentals are true, that we need our elected officials to actually do their job. And unfortunately, we've seen a pattern in recent years and even decades where people are shirking their responsibility and drawing political lines around supporting infrastructure and supporting healthcare when it's not a political issue, right? These things, if we actually develop the right policies, everyone will benefit. But I think the fundamentals are still true, that we need to educate the public, that we need accurate information that technology hopefully can help do, but we're seeing it used in the wrong way. And then just making sure that we have the appropriate policies for everyone.
What they said. I don't have anything else to add. It's perfect.
Again, thank you so much for your time. Perfect timing. We really, really appreciate it. What a great panel. We really, really are grateful for what you do and continue to do the great job that you're doing, and the community is behind you. And we're super proud of you. Thank you.
Yes, absolutely. Thanks so much, everybody. Thanks for joining us today. And please come back for the recording and share with others. Thank you.
Thank you. Thanks for your time, everybody.